All right, so we've gone ahead and we've done a postural assessment. From here, we're going to move into some movement screens. So we're going to look to see how the body is moving. We're going to start first with the upper body. Oftentimes, we refer to this as the upper quarter screen, but in all actuality, it's an upper body screen because we don't tend to look at only one extremity and its connections to the body. So you'll hear me refer to it as the upper body screen or scanning process. So first, we'll start off with the head and neck. A lot of peripheral complaints will come from dysfunction of the neck, especially if there's chronicity to it. If there's a chronic condition, you're typically going to have, at minimum, an increase in peripheral sensitization. Depending on how widespread the complaints are and how much they cross different dermatomal regions, you might have a problem of a more central nature, which is going to be your central sensitization. All of this should be some of the thought processes that you've created as you went through your subjective exam, and then from there, your body chart creation, and then finally through your scanning process. So we'll start off with the neck. What I'll have you first do is look down as if you're trying to take your chin towards your chest. Once in that position, you're going to ask for complaints. Does that change anything? For video purposes only, we're not going to have any specific pains listed here, so I'm just going to show you what you do with overpressure, but realize that if I had any problems with that movement, depending on the irritability, I would push more if it's not very irritable, or I might not push on it at all if it's a very irritable problem. So bear with that. Again, for our purposes, to show you the full screen, we're going to pretend that everything is not irritable. So pain comes on quickly, goes away quickly. All right, go ahead and look down for me. She's gotten to the end of her range. I would ask her if she has any symptoms. I'm trying to see a nice curvature of the spine. If I don't have anything, I'll come to the posterior, superior aspect of the head, and then I'm going to put this hand on the thoracic spine and just do a little bit of compression, just a little bit of a bowing of the spine from there. Again, looking to see if there's any problems with that. Go ahead and look straight forward again for me. From here, we'll look at rotation. Can you turn your head that way as far as you can? Now with this one, I can use a rough estimate of the sternocleidomastoid. Ideally, it should just get past perpendicular. A lot of people, older individuals, will just make it to perpendicular. In this case, if I want to add some overpressure, what I'll end up doing is taking this part of my forearm and putting it just behind the shoulder, ideally on the thoracic spine, or at least the proximal or medial portion of the scapula. From there, I'm going to take my other hand coming right around the ear, cupping around the ear so that I don't actually create any suction on the ear itself. I'm just going to give a slight overpressure. I'm doing my best to avoid putting pressure through the TMJ. And then I would repeat the process going to the opposite side. Again, first looking at that sternocleidomastoid. And then from there, my overpressure. Now there's one other caveat that we have with the upper cervical spine, and it's that the top portion, the top two levels, really function in order to balance the head on top of the lower cervical spine. We've got different mechanics. So what we'll see, if you could face that direction for me, what we'll see is if an individual has some problems with rotation of the cervical spine or a counterbalance of that rotation with side bending of the cervical spine, you'll see that as they get to the end of their rotation, they'll oftentimes tilt back. The reason for that is if we go through the combined motions, cervical spine, rotation and side bending to the same side, which means that if I want to keep my head upright, I've got to take the upper cervical motion and do a contralateral side bend. This is all mechanics. You can review this on your own, but you're looking for them to be able to keep their head upright in that position. Go ahead and face towards the camera again for me. So we've gone through rotation. I've shown you how to do some overpressure. The next we'll move into side bending. So what I want you to do is keeping your head forward, you're going to tilt off to the side. So go ahead and do that. Ideally, I've got a mirror up so I can see her face to see if there's any complaints. If not, obviously, just tell her ahead of time. From there, ask about symptoms again. If there are none, you're going to go over the top, bringing your forearm right over the top and give some extra stretch. A normal sensation is going to be a nice diffuse stretch across that area. If they say it's a little bit more pinpoint or a little bit more regional or specific, then you start to think that there might be a problem with the way that the spine is moving. We can test our hypothesis either way. If I take this arm and I lift it just slightly, putting the weight on my hand, relax as best you can, tilt your head back over, Now I take that upper trap and put it on slack. I can now do a little bit of a compression, so this is more the bowing. Good. And if she shifts a little bit, I can take my forearm across the side here and just try to stop that. Again, looking to see if that changes anything. Usually, if your problem is upper trap, as you put it on slack, that symptom will disappear. If it was more focal and it's more a problem with the spinal movements, you're going to have that same limitation with the sensation as well as the range of motion. So that is the cervical spine. From there, you can do extension, so looking up as high as you can. Now remember, with extension, you have a decreased amount of blood flow that happens on both vertebral arteries. With that, you need to listen for not just the symptom complaints, so the pain, if there's a neck pain or whatnot, but you also want to ask about any dizziness and be ready to help them out if they start to lose balance or whatnot. Typically with this one, I'll either skip it and do it later on when the person is sitting, or I'll do it after I've gone through some of the other testing for a vertebral artery. So I'm going to demonstrate here simply because of the purpose of the video. So go ahead and look forward, look up as high as you can. From there, she's told me whether or not she has symptoms. I'm going to go over the top of the head, and then from there I'm going to provide a little bit of that bowing that occurs again. So a little bit of stabilization, anterior and just inferior to the clavicles. I'm just giving it a slight bowing. All right? Go ahead and relax. Finally, looking at all of the symptoms. From here, we'll move into the shoulders. With the shoulders, you're looking both for scapular kinematic issues, and you're also looking for overall range of motion in addition to your symptoms. Now, the purest movement in the scapula is going to be in that plane of scaption. So what happens as somebody goes into flexion, if they've got a loss of range of motion, they'll start to dip out into scaption. If you go into abduction, they'll start to dip into scaption. It's the natural movement of the shoulder. But if we try to use that as our reassessment, you're going to end up running into problems with reliability. That's why you try to keep your patient in the cardinal plane as best you can. So first, we'll do it without any manipulation of the subject. What I'm going to ask you to do is you're going to raise your arms up just like that. Go ahead and go. Good. I'm looking for symmetry with the scapular motion. Bring it down now. Can you repeat that 2 more times for me? Good. Back down. Good. And then back down. And then from there, we'll go into abduction. So out to the side like this. And we'll do this 3 times. Oftentimes, if somebody has issues with this, they won't be as prominent without any weight. So when we look at some of the research on this, they recommend that if you don't see any issues with scapular kinematics, you throw at least a 3-pound weight in the person's hands. So you would repeat that process with a 3-pound weight. Now, when I go back to the cardinal planes, if I start to see a deviation from normal on one side and it matches my pattern, so it seems like it's related to this person's complaints, then I'll go ahead and I'll follow it and keep her in the cardinal plane. So just with this arm, can you bring it up this way for me? And I'll keep her in. Keep going. So right about there is where she starts to push to come out to the side. So I've stopped her. This is going to be a legitimate, reproducible measurement. Come back down. If she goes out into abduction, go ahead and go the same. Yep. So here I'm going to come underneath and just keep her in pure line. And I'll stop her as soon as I start to feel her shoulder push forward. Now I am watching this shoulder as she does that because the natural instinct is for her to rotate through the trunk to try to make up for that. So do keep your peripheral vision open. That'll give me my abduction and my flexion. You can do either a functional internal rotation or you can do a range-specific internal rotation, as well as the same with external rotation. So if we do the functional, I'm going to have you face towards the wall for me. If we do the functional, I can ask her to take her hand and bring it over the top of her head and try to touch as low down on your spine as you can for me. Good. From there, I'll mark it. Again, asking about symptoms. Go ahead and let that come forward. Can you do the same thing with your opposite hand? Exactly. And then from there, I'm comparing side to side. You can put that down. Realize that if I have an overhead athlete, oftentimes their throwing arm is going to have much better external rotation, so they'll be able to get a little bit lower down on the spine. Next, we're going to go up from underneath. So you're going to go like that for me and try to reach up as high as you can on the back. Again, I'm going to mark that place, let that come out, and then do the opposite side. Good. If she gets a little bit higher, again, with a throwing athlete, oftentimes their dominant side is going to have a little bit less external rotation. Now here you've got a nice example of some scapular winging, especially on that medial border, a little bit more on the inferior, which is going to speak to some of your Kibler type 1 dyskinesia. So that might be something that is related to somebody's pain. Go ahead and let this come back. So here we've gone through the active range of motion for the shoulder. Now I can do some passively. So if you don't mind, face back towards that direction. Here, the passive assessment is going to have her come up, and then from there I'll take over. And then I'm just doing overpressure. So I'm not stopping the scapula, I'm just feeling what's happening there. If I want to do just GH joint, I'm going to come, create a slight skin lock anterior, slight force down, and then I'm just going to jam that a little bit in there. Very similar to a Neer's test. If I want to go into abduction, I'm going to go out to the side. Again, first I'm just feeling how that feels. Looking at scapular motion. Then again, I can come over the top, stabilize it a little bit, and see what her end range is. External rotation, I'm going to use my shoulder a little bit to just block her. Here I don't look at the external rotation and the posterior, or retraction, of the scapula at the same time. I tend to just look at the shoulder. Gives me an idea of her end range rotation. I'm doing a slight counterbalance with this hand, making sure that I'm not jamming it with my thumb on any of her nerves. From an internal rotation standpoint, I can put her in this little chicken wing position. I'll come over the top. Again, I'm stabilizing the scapula. Let your arm rest. Thank you. And then I just give her some internal rotation. I can palpate this as I do it. So that gives us our cardinal motions for the shoulder. We can arguably, in a laying position, look at internal-external rotation at different points in the range. We just don't need to do that right now. Now, one thing that you may or may not want to do, depending on how distal their complaints are in the arm, is screen the elbow prior to doing any assessment of rotation in the shoulder. So if you think there might be an elbow component, you might want to look at flexion and extension prior to doing any type of overpressure into rotation. So I can ask her to flex up her elbows. Good. Again, looking for symptoms and any type of limitations. Bring them down. Flip your hands down. Do the same thing. Looking for any limitations, symptom provocation. From there, you can let that side rest. Do a slight overpressure. This hand is just putting a little counter force, then overpressure. So that I've looked to see if there's any problems with that. Now, the next part we'll move into is going to be supination, pronation, so just doing this motion. So if you could, put your hands like this. What I'd like to do is take this portion of your palm, you're going to rotate that up towards the ceiling as high as you can for me. Now with this one, you're trying to make sure that you don't see the shoulder AD duct underneath. A lot of times you can have a limitation with how well the forearm moves, and it's counteracted by having extra motion that occurs in the shoulder joint. From there, I want you to take your thumb, you're going to bring it down and try to bring it in as far as you can. Good. Again, you're looking here now for abduction. If there's a deficit, she'll start to abduct more on this side in order to make it so that the hands are equal. Now, if I want to add some overpressure, what I'll end up doing is first, let that hand rest, is first looking at supination. In this case, I'm just going to use a little counterbalance of my thumb, or the thenar eminence. That'll go over the radius. And then I'm going to use the pads of my finger on the opposite side that will come underneath the ulna. So I'm in this position. And then I just give a little bit of overpressure. Again, looking for any complaints. Then I flip over. I'm using pads on this side or the bottom side. And now my thenar eminence is going to go over on this side. That'll create a little bit of torque back and forth. All right, so from here we're going to move into looking at the wrist range of motion. So I'm going to have you go like this for me. Good. From there, we're going to go ahead and bring your wrists towards each other, bring them away from each other, come back to neutral here. Go ahead and point them down, and then point them up. Now, as I'm doing this, I can look from the front and slightly over to see if there's a big difference in how well she flexes her wrist or extends her wrist. If I look from the side, I can see how well she ulnarly and radially deviates her wrist. If I want to give overpressure to these, I tend to try to focus my force right around the carpals if at all possible, or the metacarpals if not possible. So if I go through and I've cleared out the elbow, I don't have to worry about some of the movement into supination, pronation. So if I go into flexion, I'm going to aim my thenar eminence right across the carpal row, and then I'm just going to give her some overpressure. This hand is either stabilizing at the back of the elbow, or it can grab onto the forearm in a relatively loose grip, just to balance out so that she doesn't go into elbow flexion. I can flip her over, bring her into extension. Again, I'm going to grab onto that with my thenar eminence. I'm going to just provide some overpressure going into that extension movement. If I want to use the radial or assess the radial and ulnar deviation, from here I can use a handshake grip. And then from there I'm just going to give her a little bit of overpressure into ulnar deviation. I can come and grab with the web space between my first and second fingers, right around the metacarpals, and from there I can provide a little bit of radial deviation. Now, obviously this took a lot of time to go through and explain what I'm doing, so the next video is going to do this in real time.